I think we can start. Thank you. All right. So, right. So here is the draft agenda, and I put a link in the chat already. So we do have as I said, we do have a packed agenda. So the first order of business will just quickly go through the draft agenda to see whether or not there are any one who wants to have the agenda order changed or any of the agenda items modified or new agenda added to. So I've already put the link in the chat, and for those who come in a bit late, I will put the link again there in the chat, so therefore you can peruse at your leisure. So there are, as I said, this is quite a packed agenda. We have about 9 items to peruse today. So I won't go through the agenda sort of in the interest of time. So if anyone who has any request for reordering the agenda because you have time constraint or you have any needs to modify or add agenda item, can you please let us know now? Okay, hearing none, then I will consider that we are happy with the draft agenda as it is. So we will move forward with the official business. So first business for today is to approve the meeting minutes of the previous 2 meetings. So we have the link already in the meeting agenda. I will post the link in the chat again for anyone who are not able to get access to the meeting agenda. So therefore, the 2 meeting notes for the previous 2 meetings, one on March the 25th, the other one on April the 8th, have already been distributed to my knowledge, and so therefore we should be able to have these 2 meeting minutes approved for today. So we will do them as a block, sort of voting to confirm these 2 meeting minutes. So first of all, let's go through the first one. Does anyone has any concerns about the meeting notes for the meeting of March the 25th, or any changes that you want to make? All right, I haven't heard anything, so then we'll move to the meeting before this one, which is April the 8th. So again, the links are in the chat for your own personal perusal at your own time. And we are quickly scrolling through this. I know that it doesn't do any justice for people who want to have the reading in your own pace at this point in time, but we are actually quite tight on times. So those are the 2 meeting minutes. So do I have any questions or any modification requests for the second meeting minutes, which is the record for the April the 8th? All right, not hearing anything, I am going to entertain a motion for someone who would move to approve those 2 meeting minutes.
Marika, I'll move.
Thank you, Marika. Anyone who would kindly second the motion?
Danielle, I'm happy to second.
Oh,
Sorry, thank you, Danielle. So can someone help me to launch a vote online poll for confirmations of the minutes?
You should have the permissions, but I'll
Okay, yeah,
happen.
thank you.
That must
All
be
right.
I got it. I got it.
Thank you, Brett. All right, at this moment in time, we have about a total of no, pretty good. So we are close to 100% sort of voting with six affirmative, four or now five abstain. The balances doesn't look too good. Anyone who do we have an online? Okay, Daniel has and also Brett have affirmative. So we have two more. So okay, so we have nine and six. So I can happily declare that the meeting minutes are approved. And then enter into official record. Oh, good. The next one we have updates. We have about three updates. So one from Bharti from Telstra Health, the other one from Brett, and then the third one from Danielle. So first, let's move to Bharti. Bharti, are you here? We don't have Bharti. So
That's all right. I'm happy to talk to it. If you could just
okay,
click on it, because that'll go to
sure.
the poll. So this was an
Yep.
action that was okay. This action was on me, from the last call. And what we discussed was Barty from Telstra Health had presented on a whole number of new items to potentially include in the AU base R7 scope. And there's a lot. And so one of the things that we said we would put forward is pop out a poll, and that's it now. I don't know, Brett, if you could pop a link in the chat. And
I
to
can pop
okay,
a
no,
link
that'd
on
be
the
great.
chat.
Thanks,
Thanks,
Stephen.
Debbie.
Um, to see like what are people most interested in to do first? There's a couple on the agenda today, but what Barty was saying was that all of these are important to them, so they don't have a preference of doing what first. So if the community has, like, if this really resonates, one or more of these items, then we could be focusing in on those, because I don't think we'll get all of them done in R7. So anyway, that's the poll. The question is, do you care about any of these? If so, vote on it, and if not, oh yeah, sure, fine. So yeah, that's the
I think,
update for that one.
right, thank you. So far, I think that we have three items kind of standing out to be sort of high priority, but we'll wait for the poll to continue. So when will this poll close?
We don't have a closing time, I don't think, for the poll, but I think we'd have to be in the next like few weeks. Maybe we'll update this. I'll send Barty an email and ask about that.
Body has just come online.
Oh,
Body,
perfect.
are you
Let's
here
throw to
yet?
Barty. Yeah.
Yes, sorry, I just dialed in. What's happening?
So, Badi, we are talking about the post that we have launched on Zulip about priority items from Telstra Health. Are you able to see the screen?
Yes, I can.
All right. Would you want to provide some supplementary information to that? And I've just asked the question about closing date for the poll, and we probably would prefer to have a closing date. So therefore, we give people a bit of a nudge for the poll to be enter into a bit more, and also have the ability to sort of make a decision once the poll is being closed.
Okay, yeah, sure. Should I start with the first one at the top?
So, so do you have any? I mean, we have the poll result now on live on screen. Do you have any additional updates on that? And that if not, then we'll move on to a discussion about a closing date for the poll.
No, I think that's all we had.
Okay, thank you. So, Daniel, so back to the questions of a closing date for the poll.
We
You
just,
mentioned about 2 weeks'
Barty,
time.
should we just like keep it open for a couple more weeks?
Yep. So, are we happy? Well, I assume that we are happy for the poll to continue for another 2 weeks, and then we'll then close the poll, and then sort of like we'll work on having the final results to help us with the decision making. So, Daniel, are you happy to send out an email to notify people about closing of the poll with a link
I
to
am, but
this?
we've got a hand up.
Yeah, Stephen, Danielle, can I just double check, just so I'm sure, from my point of view as a pharmacist, the patient safety net concession profile, is that referring to from a PBS perspective, or is there some other Medicare safety net perspective that that's talking about?
I think it is, but Barty, do you want to give just a quick summary of that one?
Yeah, it's for the PBS.
Right. Okay. Thanks, Bardita. And what about the residency status? Does that sort of impact on whether you're considered a Medicare patient or not from that? Is that why that's so crucial?
It's important in different scenarios, but the insight that I have got in community services, yes, it's more relevant from the billing and care perspective as well. But from primary care, it's just like a simple demographic information recorded in there. It doesn't really have any.
Right, right. I suppose I was sort of interested more about the consequences. I mean, I suppose if they've got a Medicare number, then that's already recorded. So I suppose I wasn't as, but if it was some definitive link back to Medicare, then I suppose I was more interested in that.
No, yeah, I don't know of any scenarios where it does have any impact on that side.
All right, thank you, Matthews. Any other questions from the audience? All right, hearing none, then I back to the questions about closing date. So I had a question to you, Daniel. Are you happy to send out an email with a link to the poll and with a notice of the closing date in 2 weeks?
Yeah, I will do that, Barty. If you're okay if we close that poll in 2 weeks' time.
Yeah, should be fine.
All right, I'll send it out an email. Obviously, we can still change agendas because we do. We ask that question. But yeah, no, we'll just pop out the poll and say like we'll close it in 2 weeks.
Okay, sounds good. All right, then we have an action item on Daniel, and then we will revisit this item in 2 weeks' time when the poll is closed. Okay, second item, Brett, TSC meeting.
Yeah, so this is pretty brief. It's just a status update on the TSC operations. So the Technical Steering Committee's meeting for the first time this week. This is really a kickoff meeting to get started with their work. So I imagine there'll be some discussions about roles and responsibilities for the work groups and the TSC, and then I'll probably come back to the FHIR Work Group as some review of our mission and charter some point down the track. I think the TSC is only intending to really start operations around 1st of June. So there'll be some information coming back through that process as we go. That's about all.
Thank you, Brett. Any colleagues on the conference call have any questions for Brett about TSC and about anything related to it? All right, I haven't seen any hands up. I haven't heard anyone wants to ask any questions. So let's move on. Danielle, Spark testing event.
Yeah, so out of the EOI that Spark had sent, which is to ask people when and where do they want to test, the majority, so the conclusion that has come to is that this will be in Brisbane again. So I'll just pop that in the chat. So it's going to be the 8th of July in Brisbane. It's actually going to be the same venue that we were at the last time. For those of you who went there, that was actually a really, really good kind of environment because so many of the hotels have like really terrible Wi-Fi, and this one was fine. So look, there's some of the QR codes. The email has just come out for folks. We'll pop something on Zulip. And so this is a testing event that's going across e-requesting, it's going across patient summary, across core, Also, HCA provider directory is involved and smart forms. One of the asks is going to be for people to look at connected scenarios. We've done all this kind of silo business. Could I generate a request and post it? But we're looking at like what are the next, like can you use this? Can you use it for booking scheduling? Can you use it for other things? So if you're interested and you can be available for that testing event, sign up and we're going to get back to you and start having that conversation around what is your priority for doing like the next connected scenario that actually uses all of these to be doing things like generating referrals, doing bookings, coming in and the response around like patient summaries. Um, so yeah, it's going to be pretty cool.
All right, thank you.
Yeah.
Anything else or any questions from the audience for Daniel on the Spark testing event in July? Okay, not hearing anything. Let's move on to the next agenda item, which agenda item number 3, AU Core Inferno PSS agenda. Sunma, are you on the call?
Yep.
All right.
So Stephen, if you could please click on the PDF.
Okay.
I know we're short on time, so I'll keep it as brief as possible.
Oh, hang on. When I click it, downloaded. So never mind. Here it is.
So the internal testing framework of AU Core has been with us for a long time, and it's been well accepted and helped the community. And it's we are just seeking approval from the working group to continuing that work into R3. And if you could just scroll down to the second page. So because thanks to everyone involved, the project is now in business as usual stage. We have a very, very nicely working stable generator. So it's pretty much can read all the changes and new profiles and just apply it to generate a new test suite. So in the document, the really only meaningful changes are the version numbers. We're now supporting R3. We're continuing this project. That's pretty much from me. So if we can get this approved by the working group.
Hang on. Oh, my apology. All right. So I think that's all what we have. All right. Anyone who has any questions for Sunma? Okay, if not, then soon are you seeking approval for this PSS?
That's correct.
All right, so would you like to make a motion?
Yes, please.
Can you state the motion?
I would like to make a motion to have the PSS approved.
Okay, so there's a motion on the table to approve this PSS as you see on the screen, and also it's embedded in the meeting minutes for today. All right, anyone who would kindly second the motion, please?
Brett here, I'll second.
Thank you, Brett. All right, anyone who has any further questions, anything that you want to raise for discussions? Okay, not hearing anything, then Brett, my apology, can you help me in launch the poll? Thanks. All right, so please vote affirmative, negative, or abstain as you consider the relevancy of this PSS to your needs. Okay, I think we have full votes already. So Brett is a +1 affirmative. Daniel, is that a +1 for you as well?
Yes,
Oh,
it is.
okay.
Thank you.
All right, so we have now 9 affirmative and 3 abstain. So motion is carried. Thank you.
Thanks, everyone.
All right, thanks everyone. So that's the agenda item number 3 done. Number 4, Uday, are you on the call?
Yes.
All right.
Yes, Stephen. Yeah.
Do you want to take over screen sharing?
Yes, please. Thanks.
Okay, I'll stop sharing you so that you can take over screen sharing.
Yeah. Is it on?
You should be able to
All
share
right.
screen now.
Right. Yep. Can you see my screen, everyone?
Yep.
Okay. So as per the agenda here, so agency is looking to deliver a HCPD, Health Connect Provider Directory Implementation Guide for the providers in Australia to provide the information of their healthcare services, practitioners, locations, and organizations, and so on, including the endpoint. So for organization, there is a scope for HSPO identifiers to be inserted in the organization profile. So due to that, we have created a, HSPO identifier, which later been requested to be inserted in HL7 AU base and getting into AU core and we deriving the HCPD deriving from AU core. So for HSPO identifier, we've been thinking of using the NOI as an identifier type, but due to a constraint in AU Core, we've been limited to use that. So we had a extensive discussion in the last Connectathon in Sydney about this, and there was the Connectathon members, the breakout session members were very adamant to create a separate identifier types for each profile, each identifier data type profile. So due to that, we have created few tickets which are in the agenda for this meeting. First one is 56096, where the scope of NOI definition to be only for the HPIO and not for the PIO as originally mentioned in the code system. So there's a ticket for that, and that's a definition we have come up with in conjunction in that from the breakout in Connectathon. So that's the definitions for that. Would you guys like to have a look at this? And if you have any comments, please provide any. Yes, Brett.
Yeah, I was just going to weigh in and go, yeah, so this is the terminology used for identifier type. So it does have an impact. It is a breaking change. This would change the definition in the PAO identifier type from NOI to the PAO code. So that's where the breaking change happens. HPIO uses NOI as well as its identifier type. That would remain the same. HPIO is unaffected. Yeah, the language in the term, the NOI term would have to change because it's basically its usage has changed. So that's that change, and I think the new term is just to support the outcome of that discussion at the Connectathon. So I think this makes sense.
Daniel, you have your hand up.
I do. So, is it could Uday, could you
Yep.
navigate to the I think there's the notes that came out of the breakout of the last Connectathon.
Sure.
Where Richard was presenting, and I know that Richard's he's on leave at the moment, and
Yep.
you're picking up the baton to take this forwards. And so I think there's quite a few people here who were at that breakout, but some people weren't. So just to provide context, there was this huge discussion around identifier type. And for those of you who are unfamiliar with that, we're talking there about the terminology in which we classify identifiers. And this arose out of the new work that the agency is doing to support these new kind of national identifiers that will be managed, as far as I understand it, by Services Australia. Um, and in the Connectathon, and I wonder, Uday, if you
Hmm.
could could you find the Connectathon notes? So I think
Daniel, I put a link
Sure.
into the chat already.
you've got it. Okay,
Yeah.
fantastic. Um, so there was this huge discussion, and it also included like V2 and FHIR. And there was an agreement in the room that going forwards, what we wanted to do was to be specific and to have a type code for every single like individual identifier. And so I guess that was the principle that was in the room, huge discussion, V2 and FHIR. Um, and that is kind of the background for what Uday is talking about here, because the type code at the moment that's been associated with HPIOs isn't unique to HPIO. So I think that's part of the discussion that is this JIRA to go, look, out of this, we've decided how we want to move forwards in Australia with how we like use identifier terminology. And I just wanted to make that really clear with people that there was this across the board discussion that also talked about like NDIS identifiers and like a whole bunch of different identifiers, and that was where we got to. But yeah, anyway, thank you for letting me just say that context.
Thank you. So Uday,
Yep.
any further informations that you would want to provide?
That's about it. Just want to, if it's all right, to make a motion to proceed to approval for this ticket.
Okay, so for this ticket 56096
Yep.
that is on the screen, Uday has made a motions to approve to progress on this ticket as described on this ticket. And can you scroll a little bit further down to the
Yeah,
identifier
sure.
type? Here, yeah.
Yep.
All right, so here is a motion on the table. Anyone who would kindly second the motion?
I'll
Brett,
second
you're
it,
on.
Stephen.
Oh, John. Well done.
Sorry, Brett. I assume that I heard you, so seconding the
Nope.
motion.
Who was it? Was it Sam?
Was it you or
Yeah.
was it Sam? Okay, right. Thank you,
Sam.
Sam. I would for the business of impartiality, can I have another person other than an agency staff to second this motion?
Okay, I'll come back. Brett, I will.
Okay, cool. Thank you, Brett. So I think that's, in my opinion, important. All right, so we have a motion on the table with a mover and also a seconder. Anyone who has any further questions or discussion point that you want to raise? All right, not hearing any. So let's call to the question. All right, anyone who would like to abstain? Oh, sorry, Brent, my apology. I'm just too
I'll run it.
fixated with the international
No
process.
problem.
All right, so here
It's
is the electronic poll on the screen. So please vote. All right. Can I assume that, Brett, you are a +1 affirmative? Thank you. And
correct.
Daniel, what would be your disposition? All right, thank you. Daniel is also a +1 affirmative. So we have 11, we have now 12 affirmative and 3 abstain and 0 negative. So motion carries, and we can end up here. Okay.
Thanks, Stephen. I have one more ticket, which
Sure.
is in the agenda item as well.
That's
So
56101,
yeah.
right? Yep.
Yep. 56101. That's so basically due to that decision of creating unique identifier types for every identifier profile. So we thought of creating a new code in that code system, identifier type AU extended code system, a code with the HSPO to support the HSPO identifiers, which will be in the HL7AU base. So that's the context of it. And the description of the code is an identifier assigned by Australian and so on there. Anybody has any question? If you
Yeah.
Has his hand up.
I was just going to point out, this is just a consequence of those principles we talked about earlier. So we would want to create a new code instead of using NOI for this purpose, which was the original kind of plan. Yep. So I think this is aligned with that. And if people are happy with the words, I think that's good.
All right. I saw Daniel has a thumb up, so I think I assume that she's happy with that. So anyone else who has any comments or any questions before I entertain a motion? All right. Not hearing anything. Uday, would you like to make a motion?
Yes, please, I will.
Thank you. Can you state the motion, please?
I create a new identifier type code for HSPO identifier.
Thank you. So that's a motion to approve 56101 to create a HSPO identifier. Brett, your hand is still up. Is that a new hand or is it an old hand?
Just that motion. It does also include revising the HSPO draft profile as well to include it. Use it. Yeah.
All right.
Cool.
Okay. So that's a clarification questions that we have a affirmative answer to. All right. Can I have someone who second this motion on the table?
Danielle, I'm happy to second the creation of the terminology code and the adjustment of the identifier profile.
Thank you, Danielle. All right. So we have a motion on the table with a mover and a seconder. Anyone who has any further questions or discussion point that you want to raise? All right. Not hearing anything. Let's call the questions. Brett, please. All right. We have a electronic poll now is available. So please vote affirmative, negative, or abstain. So I have Brett +1. And since Daniel seconded this, I'll assume that she is also a +1. All right, so we have 11 +2 who are also affirmative. So we have a 13 and 2 abstain, no negative. So the motion is carried. Thank you for that. So that wraps up the identifier items that Uday has presented. Anything else from you, Uday?
That's it. Thank you very much. And the action on me is I will create the pull request for this ticket and other one as well. So they will be coming soon into the AU-based repository.
Okay, so we have action item on Uday. Thank you, Brett. You have your hand up again.
Yep. I also just want to point out, there are further tickets coming related to this outcome from the discussion at the Connectathon. So yeah, we'll get them on the agenda for the future meetings. That's all.
Yes. Yep. I've requested the co-chairs to put that agenda items in the next meeting, so I'll get that discussion going in the next.
All right. Thank you, Uday.
Yeah.
So
Thank you.
I will reshare my screen. We'll move on to the next agenda item. All right, next one, Ricardo. I know that you're here, so you're up for the draft PSS for AU PD2. So you want to share screen?
Yep, I can do that.
Thank you. I have stopped sharing and over to you.
Okay. All right. So after earlier discussions about a potential project submission to do some work on the existing PD2 FHIR IG, I've been asked to bring to the FHIR Work Group a draft PSS to try to describe what this work could entail, which is what I've done with the team. So we put together a draft PSS to explain what we're trying to achieve, what we need, what's in scope, stakeholders, dependencies, etc. And I was probably going to suggest maybe we'll spend a quick minute, just scrolling through this, and then if there's any questions anyone has, just feel free to ask them. So if you're okay with that, Stephen, I'll start from the beginning. I might read a few things off the screen, but as I said, if then people have questions or if you want to interrupt, feel free to do it. So this work has kind of originated in a sequence of some other work that Uday has actually spoken about just before. So when we started the Health Connect Provider Directory FHIR IG project, we had a look at PD2 and we explored the idea of deriving our provider directory FHIR IG from PD2, but that idea quickly died and didn't get much traction because PD2 was not in a state that we felt we could derive our specification from and still meet the project timeframes. But in saying that, at the time, we kind of made a commitment to, at the end of the Health Connect Provider Directory FHIR IG, to come back to the community and have a discussion about potentially launching some work to refresh PD2. And if that's approved, successful, then eventually reconsider the derivation of our own Health Connect Provider Directory FHIR IG down the track. So this work is effectively for us to tackle that. So it's to refresh what we currently have as the PD2 FHIR IG and to try to derive it from core. The team at the agency, so Sam and Uday, they've done a bit of an assessment of what it would be required to execute this work, and we presented some of those insights at a previous meeting a few weeks ago. We think it's feasible. It's not doesn't seem to be a large undertake because things seem to align nicely at a high level. Of course, there's more assessment that will be needed, but at a first glance, we think this could be done. And this PSS again kind of launches the idea and the direction we would like to see if the community is wanting to take. So the scope for the project, as I said, is to update all the PD2 profiles to derive from AU Core, including base definition changes, structure alignment, identifier and name slicing alignment, correction of terminology URLs, and so on. We, in discussions with some of you here in this call, we felt that this would potentially make sense to be launched from within the FHIR Working Group, and that's why we're bringing this PSS, this draft PSS here for discussion, which you'll see that information in here. So we're thinking that the FHIR Working Group could be the primary governing group for this piece of work, even though we're effectively aligning this IG to derive from core. And then there's a few things up here that, down here that are still up for discussion. So in terms of the project team, I have some ideas of what it could look like, but ideas from internal discussions within the agency, and we'll definitely be wanting to do this with a wider group of people getting involved, so we can spread the workload a little bit more. We've also identified some of the supporting organizations that we should be kind of naming specifically in the PSS. So we have identified HL7 Australia, CSRO, Health Direct, the Department of Health and Aged Care. This needs updating. So it's not their name anymore. And the agency, the developing organization, again, I have some ideas which we can then, I guess, try to cement in the submission if we decide to go ahead with it. And the other thing, probably the last thing that I'll just call out in this quick run through of the PSS is the external drivers. Back on to the discussion we had a few weeks ago. I think the original premise of the PD2 and the original intent of the PD2 is still valid today, and this was seen as something that can be carried into the future, and therefore, I guess, doing this work to refresh PD2 and bring it to a more current state would make sense. And anyone who's then building directory specific use cases can more confidently derive from this specification moving forward. So I'll probably stop here. I'm happy to share this draft for people to provide feedback offline, and I'd be happy to take any questions if anyone's got any.
Ricardo, there are several questions posted in the chat and also a few comments as well. Do you want me to read them or you are able to see them?
Yeah, I can go through them. So any reason endpoint resource is missing from the list, yeah, probably it's a draft. We probably forgot to add it, so we'll add it in there. So also assume this will look at capability statement conformance requirements, also search. I think that's a correct assumption, Brett. I assume we will define actors again. I guess this is all down to how much we want to do like for like versus how much we want to do new, right? So if we have a good spread of people who are interested in contributing, I think we can tackle more scope. If this is going to be limited to only a few groups of people doing the work, then we probably have to control the scope a little bit more. I guess it all comes down to how many pairs of hands we'll have available to help do this work.
I was going to say, Ricardo, I mean, there's a server capability statement now, which is a producer capability already. So adding a producer actor would be relatively straightforward because it's only defining that role. Consumer, though, I think is more. That would be a bigger effort because there is nothing so far, and I assume obligations are not going to be done on this update, right?
It's up to the group, I guess, to set the boundaries, right? And then it comes down to the resources we have available to get the work done. So we've done some work in that space with our Health Connect provide directory, right? So if we're as a starting point, if we're happy to leverage some of that thinking, why not? If I think we have to go and define things a bit more from scratch, I guess that will require some further discussion. So I'd be happy, and what it seems to be happening here is, I guess we're trying to probably start to gravitate towards some of the must-dos or the must-tackles as part of this work. So if the group wants to think about what are the things we must do, I think that would be quite good, because at least we know exactly where the expectations are, and they might be different from our expectations. And if we can get that all validated, I think the chances of having a strong PSS and project scope will be much higher. So maybe there's an opportunity there for the community to think about all those non-negotiables and come forward with them. Jamie?
Thanks, Ricardo. Just wondering if you could talk through the relationship that PD2 will have with the other specs? So you said it will derive from AU Core, that's fine. But in terms of like HCA and NHSD and like the old PD spec?
So, I'm seeing a relationship develop after this work is done. Look, I can't say for sure right now that we will prioritize the alignment of the agencies provided directly for IG with PD2 immediately after we conclude this work, but that's certainly our intention. So our intention is if we have a strong, robust PD2 specification, then our plan is to go back to our Health Connect provider directory for IG and derive it from PD2. So not sure exactly when that will happen, but rather than deriving directly from core, which is what we're currently doing, we would probably be updating that. Health Direct, I'm not too sure. I think that would have to be confirmed with them. So in the chat we had with them a couple of weeks ago, they've flagged that they're currently doing a bit of an assessment of what it would take to derive their current Health Direct NHSC spec from core, because that thinking has kicked off before we started talking about refreshing PD2. But I think if we're going to refresh PD2 now, and if this aligns with their timeframes, maybe there's an opportunity for them to, rather than going straight to core, to potentially come from the updated PD2, which they already they already derived from the current PD2s. So maybe there's an opportunity for them to continue that alignment as we kind of bring a more refreshed PD2 into the fold. But look, I personally think that PD2, if we launch this work and if it's successful, I think it should be used for anyone who's doing provider directory type use cases as much as possible, and that includes the agency. So that's my view on it. But I just can't say right now whether we will and where we're going to do that. But that's certainly the agenda we're going to be trying to drive internally.
So there are two more hands up, and also there are a few more comments in the chat. So let's go to the hands up first, and then we are actually running quite tight on time, so we will have to wrap up soon. So Daniel, I assume that your hand was up before Ruben?
Yeah, it was.
Yeah.
I don't mind if Ruben goes first, but I'm happy to go.
Go ahead.
So I've not seen this prior to this call. So there's a few things that I think need to be adjusted. I think is in terms of a dependency, given the nature of PD, unless you're going to strip them, and I'm talking about like the extensions that are in base, you're going to have to list AU base as a dependency. I would also suggest that. Do we have actually, where's the section which calls out what your targeted ballot timeframe is? Because I think that's coming up. So I think you actually want to tie it to the like AU base R7, AU Core R3 stuff. Which we've got a phrasing in other like PSSs that say like it's this or the like latest available. So I think just steal that phrasing, unless you really want to tie it to a very specific version. But that's not what I've heard from you. So I think those changes need to happen. Um, and I think the other thing that I just wanted to mention was the thing that I've put in the chat about how, and I know around capability statements. There's the AUPD2, I know we call it that, has it basically has a narratively defined capability statement without using the actual structure. And so I think part of the scope of the project should be representing the rules of PD in the like appropriate FHIR structures. I would love to see that in scope, and because I think you're going to get ballot comments that are going to be negative if you don't. Like it's going to happen. Um, And I think the last bit is version. So what are we calling this? Because this would have to be our one because we've never balloted for this. So I think this
We
actually might
we
even
have
require
have,
like a
we have.
we
special
have
version
balloted.
discussion.
No, we have balloted.
You've not passed ballot and published based on ballot,
Yep, we have.
really.
Yep.
I'll go offline and ask you to prove it because I've researched and I can't find it.
No, we did. We ran it
Okay.
through. It was
An
balloted
actual
on.
ballot.
Yeah, it was only balloted on Stew 3.
All right, we are actually
Yeah.
very tight on time, so I'm going to move to Ruben. So give Ruben a minute to continue the discussion, and then we will have to wrap it up and identify action arising from this.
Thanks, Stephen. I'll be quick. Firstly, I'm making this comment not with my agency hat on. It's probably more my AFCC hat on, if anything. And that's just us being mindful about the number of provider directory IGs we have in the market in Australia right now. For this, I'm not opposed to this going forward because I think it is important to have a balloted provider directory FHIR IG out there. But in saying that, I also would like this work to really consider the strategic context and also probably ensure that there is a roadmap from all the other authors of provider directory, FHIR IGs, to somehow coalesce or converge on this one in the long term and to make that a formal commitment from supporting organizations. Otherwise, I'm a bit concerned that implementers will be struggling to decide what to implement and sort of minimizing their risks of implementing the wrong thing. That makes sense, Ricardo?
Yeah, it does.
All right,
That's
thank
it.
you
Thank
everyone for contributing. So, sorry, Brett, are you?
I was just going to add on to Ruben's point in a different way. I'm actually pretty happy this is coming back to get restarted, and I think making that relationship, like Jamie was talking about, with the other specs and having some commitments to move towards having a common set of definitions is actually very useful. Because I think as well, like at the moment, like there's a lot of read-only capability, but I know PCA has ways to submit data, and I think that would come into scope down the track. And also just people like even just like people publishing their own information that's suitable for use in directories. It's a good pattern to apply. So we can kind of put those different kind of uses into this spec and have them all aligned, which I think is a good outcome.
All right,
Yeah.
so I want to for us to agree on the sort of action item arising from this. So my assumption is that Ricardo will go away and then update this PSS document and taking into consideration all the questions raised and also comments made, sort of including those in the chat. And then come back to this work group for a second round of discussion. And if necessary, Ricardo will liaise with Daniel and Heath and Brett for further content modification on this PSS before we come back to this group for discussions. Is that a fair assumption of or characterization
Yeah,
of action?
there is, and I'll circulate the draft PSS with some updates. Look, I'll try to have a go at ring fencing the scope based on my views and also the outcomes from today's discussion. And I'll send the draft across to the co-chairs for distribution, and then maybe the first step is we open it up for a bit of additional feedback, if that makes sense, before we can put forward the final submission.
Yeah, thank you. I think
Actually,
for
can I
the
just
sort of
say, no, I think go for it. Like PSSs are just an indication of what the project direction wants to be. I don't think we have to, I don't think we need that much community negotiation on it. I think you've like indicated a direction. I think we could just go for it. Just fill
Okay.
out the yellow
Yeah.
bits and go for approval.
Yeah,
Okay.
because I think it's only just highlighting what you intend to do, like you think you will
Mm.
do, and things you intend not to do. If you want to put something out
Okay.
of scope, that's helpful too, and then that gives everyone a picture, and then everything's up for grabs anyway once the discussion starts.
All right, so we have action item on Ricardo, and we going to come back for finalization of the approval on the next meeting, which is May the 6th.
Can we probably do the week after, Stephen? I'll be
Um,
away. I'll be away on the 6th. So can we try the FHIR Work Group? I mean, I can submit it offline, and someone can probably come here and represent, but I won't be here for the discussion.
Sure, I think if we are missing the 6th of May, then the next one will be the 20th of May. Would that be too late for you?
I'm happy with that.
Okay,
So,
so
I mean, unless someone thinks and sees this as an urgent thing, which I don't think it is. I don't think the 20th is too bad.
yeah, I think in that case, then let's pencil in the 20th of May work group meeting, FHIR work group meeting to finalize this one. And we'll add it to the agenda. So when the co-chairs work on the draft agendas at the next co-chairs meeting. All right. Okay. Thank you. So
Thank you.
let's wrap this one up. Thank you, Ricardo. All right. And let me reshare my screen. So next item is up for Heath. Heath, because we are really running very short on time, we have allocated 30 minutes for you to lead us through this agenda item. Are you able to shorten it to 20 minutes?
We'll see how we go.
Okay, let's see how it goes. Do you
Yeah,
want to share
we'll get
screen?
we'll get through. Yes, I'm already doing that.
Okay.
So we'll get through what we can get through, and perhaps see if I can just get through some context, and then we can come to a recommendation, perhaps. But if anyone's driving too much, want to ask questions or whatever, I'm happy to take it. I guess I raised this as an R7 item in the context of some work that I'm doing with Fred IT and a project that they call the Patient's Medicines History. And so we're working through an implementation guide for that new piece of work, which basically derives this medicine's history from ERX data. And I've got Andrew on the line as well that's representing Health IT, Fred IT specifically for this project. So I've just got a summary. So there's a full JIRA ticket here that people can go through, but I'll just summarize it in general. So basically, as we know, various use cases for medication requests. So in the sort of from my personal experience and working on this particular project, we've got hospital medication charts, we've got clinicians that are prescribing to community pharmacies. We've got community pharmacies that are creating repeat authorizations, and we've got residential aged care medication charts as well. So there's a number of different ways and I guess workflows around prescribing medications using a medication request resource. It would be ideal as we've got things like patient summaries and encounter records, and I guess as we move longer term to clinical decision support, if we've got some guidance around ensuring that we've got consistency on how we're actually representing those medication requests and prescriptions across those various use cases within Australia. I've mentioned sort of the patient medicines history project that's going on. We already have an active script list, and as I indicated, those particular representations of this data is derived from ERX data, which is not based on FHIR. So It's very much event driven. Just probably put that in that context. So, based on my observations over the number of years working on various projects around Australia, we've got primary and secondary care where doing prescriptions where there's no feedback that there is a supply or administration of those medications. So it's very hard for the status of a particular prescription to be known in these existing systems. In residential care, we've got medication charts where perhaps the supply administration of the medications is being managed by people within the home. And certainly a defense project that I worked on where we actually had a system of systems where we had a closed loop between the prescribing system and the dispensing system where we were actually getting dispense notifications back so that we could actually notify the prescriber that, yes, that prescription was actually filled and how many further supplies were remaining. So I haven't had a huge amount of background around hospital and emergency scenarios, but at a high level, I understand there's reconciliation processes on admission, there's medication charts, obviously, within the hospital, and then there's discharge medications. So it's actually a very complex situation. Current, as I said, I'm already working on that ERX stuff. So moving on to some of the scenarios that we're looking to do. I guess if we start with current workflows and around community prescriptions, as I said, where there's no feedback. So for a once-off prescription, basically that when that prescription is provided to the patient, the status becomes active. So that's happy for people to interject around that if any of these statements are disagreed. So the question now is, when does that medication status change to completed in that particular scenario? And how does the medication request status change? And we've got a couple of scenarios in our implementations around Australia where we've got facades that are sitting over systems that have got underlying data, where that data may actually change due to those underlying system workflows. But then we've also got FHIR servers that are literally passive and require some kind of an event or update to change that status in the resources within that FHIR server itself. Brett.
I think there's questions that I have more about. Like I think if there's a prescription in a GP system, I know who owns it and who created it, and obviously that's active when it gets created. And I think the only system that would be authorized to alter that status would be the source system. So if it was to change, it would have to come back through a process, either internal or externally triggered to update that status. And it's yeah, because otherwise you have essentially misleading. Because I kind of think this is equivalent to the paper. There's an order. It's official. It's an authorization. And I want the record to reflect that the status of that, as opposed to just being data that gets manipulated. Yeah, that's all.
Yeah, and that's exactly, basically what I'm trying to outline is what are those sorts of rules around making sure that we safely change these. And there are all these various systems and workflows that we need to consider. Certainly, as I said, this current workflow or this legacy workflow where we're not getting any feedback at all. So do we just leave that medication request as active? And as you say, perhaps it is a doctor that has to make that decision to change it to ceased. And certainly these are the sorts of terms I've seen in some of the systems. They cease it and then give a reason why that, the course was complete, hence active versus ceased, that is perhaps incomplete. And then perhaps that's stopped status instead. When we go to ongoing prescriptions, where someone can actually re-prescribe, so we've got a current medication effectively on a current medication list, and then so that script has been done or issued, it's been filled, the patient comes back in, and the doctor will re-prescribe from effectively that same prescription that was previously prescribed. So that is a new medication request. But what do we do with that previous medication prescription? Do we set that to completed because there was effectively a workflow step within the system? So it's kind of an implicit saying it's complete because they've come back and refilled it. So how does that previous prescription status get changed? Again, we've got facades and servers. If we start looking at new and future workflows, and as I said, coming from a perspective of using ERX to produce active script lists and medicines histories, and the closed loop notifications of pharmacy scripts being filled, as I mentioned around the defense work that I've done, then we've got some more interesting scenarios that we want to do. So setting a little bit of context around ERX, it supports manual scripts where there is no electronic script in ERX itself. So when things are supplied by a pharmacy, there is no linkage back to an original script within ERX. So we don't have in ERX any original to update. There's also paper scripts where basically there is an electronic record of that original, but the paper is the actual legal authorization. So we can record against those original scripts, but sometimes there are gaps in the workflows where a pharmacy just takes the piece of paper as the authorization and doesn't actually link it back to the original. And there's nuances there which, Andrew can go into, but for this conversation, I don't think we need to. But then there is the paperless, which is a fully electronic. Basically, it's the full trail from the original script through to all the repeat authorizations and all of the dispensers. So we've actually got a pretty good record within ERX on every step along the way. And if I understand correctly, we will be moving more so towards this model. And there's a fairly large percentage of scripts that are actually in this paperless model, but there are those others currently still in the process around Australia. So in this particular case, when there's a single supply, it seems pretty easy within an ERX and perspective. So the supply can be linked to an original prescription. In that particular case, there's a process or an event that would potentially allow us to update the original prescription status to complete. So I don't think there's too much of an issue there, unless we feel that is, again, keeping in context, we're not updating the original prescription in the prescribing system. We're just doing this in a service that is being exposed by an ERX add-on. So it could be something that can actually be retrieved by a prescribing system or a dispensing system to basically see what is the prescribing history for that particular prescription and whether that particular prescription was actually completed or not because it was fully filled and it was only a single supply. But when we go to repeat supplies, things get a little bit trickier. So each supply can be linked back to the original prescription. In that particular case, when the initial supply is linked, should the status of the original medication still be active or should it be marked as complete? I'm suggesting it still should be active. When all the supplies are filled, then the original medications request status should be looked at as completed. Again, this is in the context of an ERX-like service that where it knows about the suppliers and dispensers, and that in theory all have been filled. However, in those odd cases where we're not able to link a dispense back to its original prescription, the chain has been broken. So even that particular dispense and all its subsequent ones, ERX doesn't have a reference back to the original prescription. So in that particular case, the medication and status remains active because there's no way to definitively say it was actually completed. So the next slide I'm going to sort of push through with some recommendations are around what I think it would be nice to include into an IG. I guess I'm presenting it here, thinking that maybe AU Base is the place to start providing some of this guidance around the status element. But is there any questions? I see, Brett, you got yours hand up around what I've presented so far and any sort of rebuttals. So Brett?
I think Andy raised a comment along those lines maybe, but I think this is really hard. I think the authority and the status of the actual medication request should remain active always unless the originating authorizer decides to change the status, like they want to withdraw that script or that authorization. And I think it's really hard to achieve the monitoring without tasks, supply tasks, and try and manage it that way. So that way you could see when suppliers are done. And yeah, so I think it's using medication request alone to try and manage that is really I think it's almost like impossible to implement as well because we have paper and we have other things going on. And then you get a mismatch between the original script and what might be held in a service somewhere else. So I think that kind of difficulty will cause a lot of confusion when your original system has a status that doesn't match an online service that's got a representation of the same thing. And so it kind of is also then who can change the status and why becomes a big question as well. Anyway, I'll leave it there, but I think it is it's not an easy problem to solve.
So we have two more hands up, Andy and then Matthew. So can we go to Andy first?
Yeah, I have issues. It sounds like to me that we're trying to overload the paper world into the digital world without actually going, the digital world is actually a different thing and can actually carry and operate in a different way in terms of the representation of the information. The medication request has inherent in it repeats. It's got information about repeats. And so I think you kind of made an assumption that an original prescription and then subsequent prescriptions, but it is actually the prescription was originally created with those repeats as part of the specification. And, it would help that we don't have, in terms of the variety of requests, be it a referral, a diagnostic request, a medication request, that we have whole different design flows around these things. Because ultimately, I think it's important to differentiate the specification of the service, in this case, a medication request that's being asked, and that the fulfillment then has different governance. And as kind of Brett indicated, the original clinician creating that medication request should be the one that decides on completion. From their perspective, the completion would obviously map to the dispense and the use of the medication and the expectation around that. But I don't think other parties should be updating status to this is fulfilled you're kind of then saying, I don't own this prescription anymore. So a variety of stakeholders can start editing that prescription. I think it's going to get really complicated to manage that information space.
I agree with you, Andy. So, Matthew?
Well, Stephen, I just was going to give some context and thanks for considering, as you said, it is a bit complex. Just a reminder that the ERX is the National Prescription Delivery Service, so it is the broader digital health infrastructure for Australia. And just as Heath mentioned about the combination between the paper with the barcode ERX, the fully digital e-prescriptions that currently make up about 35% of the transactions of prescription transactions that go through the National Prescription Delivery Service. So just for awareness.
So, and again, keeping in mind that I'm not talking about trying to update those original prescribing systems here. This is really another view and is trying to be a best, what's the term you use, Andrew? Around this, the best known medicines list or something or other that.
Yeah, best possible medicines history. Yeah. Best
Yeah.
possible medicines history.
So this is independent of the actual prescribing system. It is intended for those that weren't the original prescriber. It's including pharmacists when they probably don't have the full history of all of the dispenses that were done as well. So it is that best possible known. So the idea of trying to actually say, well, we think that this prescription was actually completed because we know that there was 5. And that's why in these recommendations, I'm kind of trying to put it in terms of when we don't know, then it kind of falls back to, yeah, we don't have enough information to say it's anything other than active. And when we know that, yes, all of the supplies have been done, only then is it completed. And so that's the kind of level of I've got the 4 dot points here that I think are outlining the 4 scenarios that we know or might be possible. And ultimately, it's being clear that we're just going to leave them inactive and you can't really use that status. And this is really troublesome from my perspective, from creating a patient summary perspective in a automated way, because we can't rely on these things being non-active in prescribing systems. So if it was like a best practice that was generating a medication summary or exposing the list of prescription history, what's their status, and then someone trying to consume that and actually generate a patient summary from it. So as I said, the only one I think that can safely be marked as complete. And if we feel that even that's not safe enough, if we do know, and again, ERX has the knowledge to know that in certain circumstances, so is it worth marking it as completed, or we just make everything active forever? Brett?
Yeah, I think part of the problem is that there is a medication request record created that is actually an authority to do something, and that has a different purpose than a summary of that at some point, or a modified version of that. And so how do we tell the difference is the question, because orders,
that's next week's topic.
Orders and prescriptions, right, are like are official. They're authorities by the clinician to do something.
Yeah.
And so we need to know that that exists. But as soon as, like I say, I take a copy of that and put it into a summary, that's no longer an authority, right? It's not the same thing. And also, I guess if you're representing views in a centralized service, it's also not necessarily the same thing. So I guess you got to get to that.
So I just need to sort of do a time check now. So we have about 6 minutes left to the call. I think probably we won't have enough time to even start number 7, 8, and 9, which will require quite a significant amount of time. My suggestion is for us to continue the discussions on this topic until the half-hour mark, where we can then close the meeting, and then the other agenda items would then have to be hold over to the next conference call. Are we okay with this suggestion?
The suggestion
All
of
right.
continuing conversation.
Yes, suggestion is to continue the conversation for this topic until the half-hour mark, and then we hold over the other remaining 3 items to the next conference call. All right. Okay. Thank you. Let's continue.
So, as I said, this is in summary. What I would like to perhaps get some additional guidance into, possibly AU based, just to outline within Australia, these are common scenarios. And if you're actually providing a response to a query of your medication requests, now, obviously, some of those are original medication requests, the actual order, and then there's others that are actually receiving that, like ERX. So ERX is actually storing the order and providing that as a view. And there's other APIs that actually allow the pharmacies to pull that order down for the purposes of dispensing, but that's not the purpose of necessarily this medicines history kind of scenario. But again, that's just one scenario, and there are many scenarios, as I outlined, that what can we actually provide to implementers as the guidance on how to manage status on a medication request for some of these scenarios?
Jamie, you have your hand up.
Thank you. Just a question, and Paul, I think you mentioned this in the chat too. When a prescription becomes inactive because it's expired, say after 6 or 12 months, is it logical, I guess, in that circumstance for the request to remain active, given it is theoretically no longer an active request?
So how does it change though, Jamie? That's the thing. Like, you take a FHIR server, it's sitting there as in a passive repository. It's just a database. So something actually has to trigger an update to that resource. I mean, even in facades, the API could take into consideration the expiry and choose to do something with it. But what's the guy like? We want to make sure that that's done consistently as well.
Yeah,
so
and I think that
expiry
would be
may actually be
thing.
another guidance scenario that we need to consider. But I think certainly from a FHIR server perspective, that's really challenging.
Daniel, sorry, Ruben.
Thanks, Stephen. I guess my first question here is, what's problematic with this guidance not actually being included? Because I've just read through the code system definitions for these status values, and by definition, they look almost exactly the same as what you've stated here. So I'm kind of trying to understand what we gain by putting this in AU base.
So there are certain, certainly on the experience I've had with some of the systems, people are marking them as completed when they don't necessarily have the knowledge that they have actually been dispensed. And
so that is, strictly speaking, non-conformant with the FHIR core spec, right?
Okay.
If you look at the definition of completed, it actually says that all actions implied by the request have occurred. So if they are signing that status and they don't know that those actions have occurred for sure, they are non-conformant.
You could interpret it that way. And that
I don't see any other way you could interpret that.
I would say that's what it says. Yeah, I think too, like a part of it is like, yeah, incomplete knowledge is a problem, but also like even things like expiry, that's a policy position, not a like it is something you might want to assert, but like it's not necessarily true, right? It's because I think there's other codes as well you could use that would make more sense in those scenarios other than completed. Um, yeah,
Absolutely.
so yeah,
Yeah.
so I think that's the
So
kind of thing I think it's good though to have this discussion, I think, because
Mm.
it is really confusing as to what to do, and where to apply
And
things.
in
Yeah.
some of the discussions that I've had have also indicated, oh, I've just filled the first prescription,
Mm.
and so I'm going to mark that as complete. But I've had to actually argue otherwise, that no, that's not appropriate, in line with what you were saying, Ruben, that this is the definition. So just bringing this out as additional implementer guidance in a fairly easy to uh, reference position, maybe restating what the FHIR spec already says, but not everyone actually goes and reads the specifics of everything. And as I said, it's a one way of interpreting it. Others might interpret it slightly differently. And as Jamie talked about, the expiry. And, is it sufficient for a doctor to mark something as completed just because the the patient said that they actually took it and they're coming back and actually having prescriptions? So, I mean, we're getting into nuances, but some general guidance would be nice, I feel.
Um, yeah, I think we are actually at time, so we will have to come back and revisit it. So I think that this is a very complex issue, not just complicated. It's actually very complex for a number of reasons. Number one, there are different workflows in the acute care or in hospital environment in terms of workflow versus the community or primary care. So the question that we need to address is, or there are a few questions. Number one is, are we going to sort of create some kind of guidelines that cover both the acute care or in-hospital setting and also the primary care settings, or are we just trying to sort of do one at a time? And number two, I think that as Andy rightly pointed out, there is the issue of the paper world versus electronic world, and then there is the issue of a single no repeat prescription versus a sort of a prescription with multiple repeats. And in those kind of scenarios, some patients might only have one or two repeats filled, and then the medication prescription got stopped because of complication, and a new one with multiple repeats starts. So how do we manage those kind of complexity is actually very challenging. And I posted in the chat a bit earlier, I said, look, Michael Osborne's suggestion of looking at how task resource can help in managing this kind of workflow issue would be very useful. And e-prescription has done a very good job in creating some patterns to enable us to sort of borrow. So I would suggest that we need absolutely further discussions, but we don't limit our discussions to the paper world, but also consider the patterns that has been developed in the e-requesting and see what we can borrow.
Because I'm sharing, I don't seem to be able to put my hand up. That's not what I'm asking for guidance for. That's a whole nother workflow thing, and that's not what I'm trying to actually get guidance around. It's just simply, if I've got this amount of this information, what rules should I actually use to determine that status? So it's not necessarily about exchanging status and asking someone else to change their status because of an event. It's actually just guidance around, I've got this information in my system and I want to be able, what's the rules around setting completed and active? And yes, I did have another slide, but I stopped there around cancelled and stopped and stuff like that. And yes, it is a bit of a repeat around the FHIR definitions of the statuses. But I just think it's worth putting it in the context of Australian community pharmacy in particular.
I think that's a good way to put it, Heath, because like it's the criteria that would be met to use that status. I think that's actually a helpful way to think of it. And then the other questions can remain, but it's
Yeah, the whole
yeah,
workflow
yeah,
things, there's too many of them. We can't solve that problem. But
yeah.
at least if we've got some basic stuff around, based on the knowledge I have, can I make a definitive decision on what the status should be?
Yeah, I think that also leads even around what the comment Stephen had about some of the clinical actions, like say I stop stop a script because you have an allergy or something. What is an appropriate status to set that script to, right? And stuff like that. So it's more, I think, yeah, some guidance on those things would be good.
Yeah, and it's very common scenario yeah, for sort of a lot of patients. One typical real life example is that patients are being prescribed an antihypertensive and then sort of reported back to the prescribing doctor that he or she has considerable complication or side effects from the drug, and then the 5 repeats sort of got stopped at the second repeat, and then sort of a new prescription being issued. So these are complex issues I think we need to discuss. And I still don't think that we can dissociate. I mean, we should bring the paper world into the electronic world, and sort of Andy made a very good point. I think we should examine sort of the guidance in the context of the electronic world. Okay, so next step, Heath, moving forward, what would you like to be the next step?
Well, I don't really want to spend too much more time in these working groups, but I guess it would be nice to get some kind of resolution. Um, you know, so there is the Jira card. I don't know if people want to make comments on it, but I mean, I would be asking the committee or the working group to perhaps draft up a resolution
I
on.
think that would be a good starting point. So we have the Jira ticket on in the meeting agenda today, and people can access the Jira ticket and then make sort of comments and propose some sort of options for consideration. So I think that would be a good starting point. And then if you can send your slide deck to Brett for him to be included in the meeting minutes, and then people can also peruse it as well.
Yeah, and I guess the key part of that card is the recommendation that I put in that final slide. So that's if people want to actually just put it in the context of comments in that particular comment, and that's what I'm actually asking for a resolution on, is that
Okay, that'll be good. So we'll come back at the next meeting to revisit the topic. All right, with that, I think we will close the meeting today. Thank you very much, and thank you everyone for your excellent contributions and participation. And I will look forward to the next meeting, especially on this topic, Heath. So we'll wait for folks to comments and make recommendations on the Jira ticket. And then if you can send Brett the slide deck, then people can also have a bit more contextual information as well. That would be wonderful.
Thanks, Stephen.
Okay,
Thanks,
thank you,
Stephen.
everyone. So
Thanks all.
see you all next
Thanks,
time.
Stephen.
Yep.
Cheers.
Thank you.